We're going to get started. This is IC19, Wheeling Through the Lifespan, addressing changing needs in the adult neurologic client. The speakers today, I'm Rachel Hibbs. I'm a assistant professor at the University of Pittsburgh, but clinically I see patients at the UPMC Rehabilitation Institute in inpatient and outpatient settings. Becky Russell also is a PT, the therapy team lead at our Center for Assistive Technology, and Julie Gallagher, also a PT at UPMC Children's Hospital Inpatient Unit. We have no financial relations, and if there are pictures on the slides, it's just pictures that were publicly available on the internet. The objective, so we'll address some considerations for wheelchair prescription when working with people with adult onset neurologic diagnoses, and talk about how we can modify a current device or when to pursue a new device, and talk about educating clients for short and long-term device options. So I'll start by talking about who are we talking about? Adults with neurologic conditions, to really understand what we need to consider for wheelchairs, what type of device does it need to change, what should we be expecting for somebody to change as time goes on. So really talking about the disease or disability itself, and then the different processes as people age. Is that part of just regular aging, or is that part of the disease progression? So is the disease progression something neurologic, like do we expect changes in strength or tone or sensation? Do they have injuries like from musculoskeletal overuse, posture? Have they had a skin breakdown or something like that? And then what is their current and anticipated future functional status? So do you anticipate improvement, decline, or status quo? And obviously this varies depending on what the type of diagnosis and disability is. And then again, on top of all of that, think about what are the effects of aging, and again, typical aging, and then do we expect different aging based on the diagnosis? So we want to get individuals chairs that fit them, and better fit, better function. We all know all these things. But it might mean something that's less adjustable if we're getting something really custom. And so how do you walk that line with somebody that you might anticipate will change? So a client's current presentation, with an awareness of anticipated diagnosis-specific changes over the next approximately 5-ish years. What about potential weight gain or muscle atrophy, changes in spasticity, posture, balance, coordination? What about their wheelchair transfer skills? Might they get better? Are they going to get worse? And changing environments of use, are they going to move, or do we anticipate something different there? So they're probably more than that, but those are the things that I think we all think about in general when we're ordering a device. So then what about at 3 to 6 months? For some people with different diagnoses, that might change pretty quickly. Maybe think about somebody with a new traumatic injury, like a spinal cord injury. You expect them to change in the first 3 to 6 months, usually in the upward direction, at least as far as learning skills and stabilizing, those sorts of things. Maybe have neurologic recovery, but for somebody who maybe has a diagnosis like ALS, we might expect significant change in the downward direction in 3 months. And then think about the ones sort of in the middle, like maybe a relapsing MS or something else where we didn't expect major change, but it is always possible in a short time period. Oh, I forgot there were more. So, yeah, change in environment. You're expecting maybe atrophy. Might expect body size to change. You might expect maybe a change in life roles. Maybe they're working and now they're not. Vice versa. All sort of extra layers to sort of add on top of that. And then, sort of just for emphasis, but the same things at a year that, again, it might change again in the next 6 months. And then again in the next year and the next year after that. And so it's sort of, at least for me, can get overwhelming of how am I supposed to manage all of this? And, um, you know, it's just a lot to think about. It's a lot to anticipate and try to understand how we're going to. I didn't think about all the little bubbles. I'm trying to move them forward. But how are we going to sort of take all of this in and get people the right equipment? So a note about an injury event or a single event versus progressive condition, which I already alluded to, but for someone with a single event or injury, like a stroke or a brain injury or a spinal cord injury, anticipate slow change, initially the big change, but then slow change maybe after that. Um, the age at the onset is a pretty big factor. We expect pretty different outcomes for maybe a 30-year-old who had an aneurysm versus an 85-year-old who had a stroke. They may have the same sort of symptoms or signs, but pretty different function, and anticipate that the progression or decline in function may, happen more quickly and never quite peak as much in the older adult. Potential for increased complications, more dramatic change in the increased time post-injury. People seem to level off usually after so many months after initial injury, but maybe 20 years post. I think we could probably all think of a client that had whatever injury 35 years ago, and they've been sort of doing the same thing for 35 years, and now starting to see things really, really change, and it's maybe in a dramatic way. And then emotional adjustment, maybe focus on that more in a rehab setting and make sure people talk to a counselor and they're working through the emotions of this big life change. But again, most people, I'm making some broad statements, but most people sort of level off for a while and then maybe don't continue to have that sort of support, or and maybe don't need it. But if they're sort of slowly declining over time, it's maybe harder to adjust to change or harder to realize that you need to adjust to change. And those are all sort of things to think about. Progressive conditions, we would anticipate a faster progression, again, relative to those others. Maybe concern for complications a little higher than overuse injuries. Expect other systems to be more involved than maybe overuse or other things in the other group. You need continual assessment and adjustment, and again, depending on the diagnosis, the intervals may be different, and emotional adjustment sort of ongoing with clients with these types of diagnoses. And then again, on top of all of that, what do we think about with aging? This is just from a textbook about what aging in older adults. This is not specific to any disability, but skin changes, muscle loss, bone loss, stiffness, pain, decreased height. So we don't anticipate people like grow, like we might talk about when we're talking about kids, but we might anticipate that someone's height might decrease. Sensory changes, vision and hearing loss, cognitive changes, even with absence of an actual diagnosis like Alzheimer's, increased risk for lots of things. And we don't need to keep going and depress everybody, but what things to think about that even healthy people with, we need to think about that their skin is different than it was 20 years ago, and that their joints and bones and all of that is different. And then there's some diseases that do also have some specifics for aging. And this isn't a pathophysiology course, so I'm going to stop there. But just note that if you're working with a specific group, you should be considering that there are some specific aging considerations for each diagnosis. So we have to consider the past and the future when making decisions for the present. That's true for everyone, but again, maybe more so for this specific group we're talking about today, that it's really useful to know, for example, someone who has MS, how long ago or how long have you been needing a wheelchair? How long did that take from your original diagnosis to now? You've been using a manual chair for that long. Okay, well, 20 years you've been using the same thing, you're still sort of functional the same. Maybe we don't expect it to change quickly versus someone who says, no, every 6 months I have another episode and now I'm getting worse and worse. Those are really important things to know from the sort of past to predict the future. Uh, yeah, I sort of spelled it out here. So diagnosis, onset, et cetera, et cetera. The present, of course, we need to know what's going on with you right now and get accurate information about what your current asks are from the equipment. Just because you have been using a manual chair for 20 years, you might need it to do different things now. And then what do we anticipate, changing? And again, you could go back to all those bubbles in 3 months, in a year, in 5 years. So some questions. Again, this is pretty similar to what we would do with anybody, but is the current equipment working? What have you used in the past? What do you think you need next? What are you asking it to do? Do we transition sort of now if somebody thinks they might need something different or they're sort of progressing more quickly? Or we're kind of regardless of the answer to that question, do we sort of prepare and try to get them more than they need? Now anticipating change. Yeah, what are their goals? And how do we develop the clinical picture to select the right thing?
So now we have a crystal ball, and I think everybody probably has one in their clinic. Mine, it looks like that because I work with kids. But actually, we do not have them. It's really hard to predict what an adolescent for me, but also I treat young adults. So what they're going to look like in a few years. And we want to make sure, like Rachel said, that we're planning for that, but also not overshooting, right? And ordering something that they're not going to need or is taking up too much space or is broken by the time they need that part. We want to make sure that we're thinking about the specific components that we're selecting so we can maximize their independence. So first, we will talk about manual wheelchairs. If you work for one of these brands, I looked all of this up on the internet. So if it is different, you would need to change the internet. But if you are curious about which chair is going to match your client's needs, there's a cute little chart. Someone corrected me last time I presented and it was wrong on the internet. Um, so if you are new to the world of manual wheelchairs, here are two of them. Again, we're just picking pictures from the internet, so this is not a brand specific lecture. But some terminology to think of: the wheel spacing, it's the space between the wheel and the chair. The seat width is the width of the chair to the outside frame, camber plug, camber angle, and then the side and clothing guard. So when we're thinking between rigid and folding frames of chairs, we want to make sure we're opting for the best frame style to meet their needs, right? And this is similar for anytime you're having that discussion with somebody, but making sure that we're highlighting the fact that rigid frames tend to have more efficient, uh, be a more efficient choice for someone who is primarily propelling with their upper extremities. And I think a common misconception is that people, if someone is ambulatory or they're doing a lot of standing transfers, oh, we should order a folding frame. There are so many ways to stand from a rigid frame chair. And that doesn't need to be the direction you steer your client simply because the way that they stand. So how do we order a manual wheelchair that will continue to meet a client's needs if their hip width changes? Some things to think about when we're ordering a manual chair. Do we expect significant lower extremity atrophy? So, did someone have a complete spinal cord injury? Did someone have some demyelinating condition? Are we expecting that dimension of their body to change? Have they lost significant weight in the hospital or from something else? So, they had some other illness. They're on some medication to lose weight. Are we anticipating that that is going to change? Are we concerned that it's going to go the other direction? They were very active for a while, now they're not, and we anticipate that maybe they're going to be gaining weight. And how can we combat this in ways other than just ordering a wider wheelchair? Can we address their diet with a dietitian? Can we talk about exercise and access to different recreation opportunities? It doesn't necessarily just need to be, let's just buy a bigger wheelchair. Can we talk about some other options? And how does their diagnosis specifically impact those decisions? For most clients, ordering a wheelchair at their current seat width is okay. And we don't need to guess and add inches or subtract a lot of inches. That's probably not going to work well for them. Um, And that's just, again, the crystal ball would come in handy there for we can't exactly decide where someone's going to be, but we don't need to. I remember in PT school when I was learning this, everyone's even on our test, it said that you have to add 2 inches to someone's hip width when you're ordering them a manual wheelchair, which if you've ever watched someone push a too wide wheelchair is not really efficient. Um, Camber. So you can order adjustable camber plugs if you're not sure what's going to be the most efficient for them, or you're going to need to adjust how the wheels are spaced and how they're angled towards them. When you remove that camber, you're able to get a little bit wider seat width. You can eat up some of that space if someone's hip width is changing. The opposite is also true. If someone's hip width is getting narrower and they're sort of starting to push in this position, you can increase that a tiny bit to bring the wheels closer to their hips. Many brands offer wheel spacers if we need to adjust the wheel spacing. And you could consider a seat or front end taper to suit the client's needs and your predicted change in their body habitus. I literally just said all of those things. I forgot there were 2 slides. You can also space out side guards if needed. Again, if they're getting too close, but we still need the side guard, most brands have a spacer where we can pop that out a little bit to give them a little bit more space. And you can even increase the cushion width then to make sure that it still fits them. Have you tried everything? Have you done all of these things on my 2 slides? It may be time to consider reordering a new chair that has a seat width that allows the protection of the lateral lower extremities, but still permitting access through doors and optimal upper extremity positioning. If you need a seat width that makes that door access tricky, this person has now grown, you might want to consider if a power chair works for them, because we can adjust that a little bit differently, right? Versus the spacing of wheels on the side of a manual chair. Sometimes you still run into the same problem depending on the width or the doors they're trying to access, but that is an option if we're really tried everything there. And I would also add that you will need to justify this if we're in the less than 5-year range, or if you're in kids less than 3-year range. If the chair is harming the patient, that is a justification, right? Sometimes it's a lot of justification that ChatGPT could maybe help you with, but that you can use that. It's not working for the client. Some payers might need a lot more documentation of that, but if it's not meeting their needs, then we need to get something that does. All right, so seat depth. Okay. Do we expect the patient or client to increase in height? And I would say that's probably more in the adolescent or young adult range, specifically with young adult males. We might even see them grow to age 25. So they get hurt at 18. They actually might be several inches taller by the time they're 24 or 25. And as Rachel said earlier, we might also see somebody shrink. So something to think about when you're ordering seat depth. The biggest thing, I think, when we're talking about a changing client whose needs are changing, in either direction, is do we expect to change their backrest positioning or style? So initially, maybe someone with a new spinal cord injury, we have a deeper back with more contour lateral support. And as they improve their trunk control, or we mess with their seat slope, we might not need as big of a backrest, but did we order a chair that's so big to fit this big backrest? The opposite could also be true with some of the progressive or a decline in function. Did we order a chair with upholstered back, and now they need a little bit more trunk support and there's no room on the chair to put that? So we want to make sure that we're talking about this and using our crystal ball to predict which way are we seeing this slide, so we know what to order, we know how to adjust their seat depth. You can add a depth adjustable back that adds more weight, that adds more length to the frame, but it could be an option. You could also add custom frame depth to the front of the chair so that if needed, you could sort of slide forward on the chair. That does impact your wheelbase and center of gravity. No choice is without a con, but it is something to think about. If you need to, or you are able to on a manual wheelchair that you're adjusting seat depth for, you can move the back gains. You could modify the seat to back angle. If you need to open that up a little bit, you could see what adjustability exists in the backrest hardware, or switch to a backrest that has more adjustability in the hardware. Change the backrest completely. Depending on the frame style, you might even be able to change the cushion depth to simulate a longer or shorter seat depth. So it also come into play if someone is becoming more increasingly kyphotic and we need to adjust how they're sitting in the chair. You could also order a new seat upholstery if it needs to be shorter or longer. All right, seat height. What seat height is going to allow for ease of access in patient and client environments, and what seat slope is required for optimal pelvic positioning and wheel access? Seat slope or dump, which is a child's favorite wheelchair word, is the difference between front and rear seat heights, and it allows for pelvic stability and improved wheel access. Ordering a chair that has an adjustable rear seat height is going to allow for ease of changes. Again, if we're thinking of somebody that we're predicting changes for, ordering something with a little bit of adjustability is wise. Ordering something with a ton of adjustability sometimes comes with a lot of cons of broken parts, moving parts, and less efficient push. Multi-position caster forks also allow for ease of changes. When we're thinking about center of gravity, we want to make sure that we're addressing the most functional and efficient center of gravity. Someone with a new diagnosis might need a little bit more stability as they're learning wheelchair skills. And as they improve, you might be able to move that center of gravity more forward. I'm also a big pusher for the fact that we might need to just order it in a more forward position, use anti-tippers, and use a lot of I don't know, wheelchair skills training and therapy to learn how to use that efficiently. Sometimes when the chair is ordered super stable, no one is teaching the wheelchair skill, or the wheelchair skill is too hard. And so then we're just continuing to do that forever. The opposite would be true if we're seeing someone lose function and they're tipping over all the time, or they're just not able to be as stable in their chair. You can move the center of gravity more rearward. When we are thinking about wheels, we can consider their seat height requirements, which could change again depending on somebody's need for increased or decreased pelvic stability. Um, might not really anticipate someone's upper extremity length changing, but they could. And how they're pushing. If they're getting stronger or weaker, they might need different access to their wheels. Lighter wheels, spoked wheels decrease the overall chair weight and aid in decreasing um, the risk of upper extremity overuse syndrome. That is my mini soapbox moment about my disdain for mag wheels. All right, power wheelchairs. Why are we transitioning to powered mobility? Maybe because the manual wheelchair is no longer most effective due to their diagnosis or aging. They might be more fatigued, they might have more weakness, or secondary conditions. You know, they have osteoarthritis, rotator cuff, overuse syndromes. I would also consider that the patient has expressed willingness to learn safe wheelchair skills with a power chair, and they're going to pursue continued follow up, not just an immediate, oh, hey, let's just switch your chair and now you have this. And in a case later, we're going to talk about a personal story with that. And that the patient is able to meet or modify their transportation needs. We don't want to just automatically switch to something if they've been breaking down their chair in their sedan and driving themselves for 20 years and have no other option. When you order a power wheelchair, you have a lot more adjustability within the seating system to accommodate for changes in body structure and function over time. You can adjust headrests, armrests, foot plates. There are available width and depth packages for the seat pan and the back support. There's a lot of aftermarket options. You can see a lot of them in the exhibit hall. There's also a lot of drive control options. Again, this is from the internet. Take it up with the internet if you do not agree. Postural and positioning supports, so many things that you could add on a power wheelchair. And I think the biggest thing to talk about here for changing a client who has changing needs, particularly if we anticipate a decline, is that it might make sense to order the supports you predict that they're going to need in the nearest future. So they're already on the chair and they're not having poor position or having falls or having issues while we wait for that to get authorized. The caveat being you need to be able to justify it for it to be on the wheelchair. And that is going to be different with different payers and different vendors. But I think particularly some of these postural supports like a chest strap or chest harness that this person is not using a lot, but we anticipate they're going to need soon, or lateral supports. Maybe we have this on here so we're preventing scoliosis or we're preventing this other musculoskeletal concerns from their positioning. And I would recommend having good relationships with your vendors. So if you realize you forgot to order something, they can help you out quickly. Two of mine are in the room. And again, I think it's most important to order what you think they're going to need, but also making sure that if there's somebody who's going to lose all of the things, maybe that's not the best decision, right? They're going to take it all off the chair and put it in a bag in grandma's basement. Then what are we going to do when she needs it in 6 months? So know your client, know your vendor, and pick the best thing for them. Drive controls, lots of options for drive controls. And if you anticipate your client is going to change, I would recommend discussing this with them to begin with. So, in either direction, hey, right now we're going to use alternative drive, but you're still working on increasing your upper extremity strength, range of motion, coordination to maybe drive sometimes with your upper extremity. The opposite is also true. Right now, your arm is able to do this. When we determine that that's not safe or efficient for you, we do have a lot of other options. And I think it's important to have those discussions when you're ordering the chair so that someone knows what to expect and it's less, um, still could be frustrating for them or could be exciting for them. But when you talk about it first, I think it's very helpful. Some benefits for power seat functions if you're thinking about making a justification potentially for something that you're not sure you're going to need yet. But how could we justify it now with things that insurance likes to look at and have it available to use later? It's a non exhaustive list. Power assist, the fun unicorns in between manual and power. There's also a lot of cool new ones in the exhibit hall if you're interested. So what about powered assist? Power assist. Powered add-ons to manual wheelchairs can help improve ease and speed of propulsion. We use them for the power benefits on a manual chair to decrease overuse syndromes, ease transportation difficulties, or even just with obstacles in the community. And they could be a bridge from manual without power assist to a full power wheelchair. But like any powered mobility, they should be assessed for readiness. There's a lot of different options out there with different levels of safety or ease of use for potentially an aging client or someone whose cognition is decreasing. Users should have repeated trials before ordering to make sure that they are safe. And absolutely, absolutely, they should have repeated training with a clinician once they have the product so that we are not giving someone this really cool rocket blaster on the back of their wheelchair that they immediately take off a curb. Um, Lots of new options out there from both push rim and joystick mounted. And again, it's really going to depend on your client and what they need. But I would urge you to make sure that the seating needs are still being met by their manual wheelchair. It might seem very convenient to them to still have a manual wheelchair and then a powered add on. But if the manual chair itself is not meeting their needs, that's kind of a risky thing to just order for someone because let's say in a year now they need a power chair and they need the seat functions that come with a power chair, but we just told insurance this power assist and their manual chair is just fine for them. So making sure that your crystal ball is working so you can figure out, are we going to be able to use this manual and power assist combo short of a major clinical change for the next several years, then it really might be worth it. It might be something you use some of the time. It might be something someone uses all of the time. It works for them for a while. But if that's not the case, I would really urge you to be careful ordering that combination of things when it could be very impactful for the power chair available to them in the near future. Speaking of justification, our favorite thing, writing letters. You want to make sure you're accurately describing the change in medical status and asking your provider to do that in a detailed fashion as well, because as much as we therapists love to write things, the insurance loves what the physician is saying. So, working together to make sure that we're both justifying the same change. How is the current device no longer meeting their needs? Be as specific as possible. I have used a picture before. Put whatever you can in there to justify, hey, we know you bought this other chair 3 years ago, but now we need this one. Listing what modifications were made and trialed and what came from that. And what things do we really need for this client for it to be useful that aren't possible. I do also recommend, if you're working with a particularly challenging insurance company, to look up their policy, unless you have the AI software that does it for you, and then making sure that you're putting in the buzzwords that they use to look for, either with a person or a bot, to figure out what they're going to cover the most. So if I know, this insurance plan is looking for X, Y, and Z in a diagnosis to cover a power chair, those exact phrases are going in my letter with all of the other data, so that hopefully that can justify it a little bit stronger, particularly when we're looking in the less than 5 or 3 year range.
Sorry, I'm gonna jump in before Becky goes. I'm just gonna add a small plug that using something objective, even when you don't think you need to, can help you with that process of if you took a baseline of they can push at this speed or they have this strength or whatever, maybe take more than you think you might need, particularly for people that are going to progress, because then you have something to say, this is slower, here are the speeds. This is weaker, here are the grades. Those sorts of things, rather than just having these words that don't really mean anything. That the balance scores, transfer levels of assist, sometimes that we maybe don't get into quite as much detail in the seating world as they might in like a regular outpatient or inpatient therapy world, that those can be pretty helpful, but you need to have them the whole time, not just at the end.
That was a nice transition to my portion of the presentation where we talk about some subjective things and the kind of subjective process of the having that conversation with someone and working through the process of making that decision to transition to something else. So when we are looking at that individual and the kind of discussing those aspects of the wheelchair, we basically the use of assistive technology is personal, it is complex, and it has a host of confounding factors associated with how that individual is using the device in their community and their environment. And there's a lot of things that we need to be thinking about in order to ensure that that device is successful for them. So here I have kind of a list of themes of that are kind of describing barriers to assistive technology. So we are going to kind of focus on, our ultimate goal is to prescribe a device that is going to be used by the user. We want them to feel that it is meeting their needs. We want them to feel comfortable in it. We want them to like the device, because if they don't like the device, that they are not going to use it, and that is going to ultimately be a wasted resource and very unhelpful to them. So with these kind of themes here, this was described by a meta-synthesis that was published in 2022. I think it's a really helpful framework of variables that we can be considering as we're working through that process. This is not an exhaustive list. There were a lot of things on there. I just pulled a few of these, but this can also be overwhelming. We can't touch on every single one of these variables when we are working with someone, particularly in the outpatient setting. We don't get a lot of time with someone. So what we need to be able to do is to kind of prioritize our time with that person and kind of figure out who they are, what their needs are, what they are looking for, and then kind of work with them through that process. So, some ingredients for a successful device prescription. We want to be thinking about, we want to have clearly defined team roles. We want to make sure that we are focusing on that client throughout the process. And we need to be open to, coming up with some creative solutions to meet someone's goals and needs. And then also considering that kind of ongoing assessment and follow up. Um, you've probably seen this in some iteration at least 3 to 5 times already this week. But I'm going to just make sure we're all on the same page. So our client is at the center. They are the most important member of the team. They need to be, feel heard throughout the process. And we need to be making sure that all decisions that are made, recommendations are made are based on their specific wants and needs. Just to kind of reiterate all of the team members, our manufacturers and our ATPs, we need you to be, very knowledgeable in understanding the products, particularly if we are making recommendations to change to a new product. What are some of the nuanced differences that this person can expect when we go from one thing to another? That can be from down to the component selection, all the way up to from changing from one power chair to another power chair, an old model to a new model. Some of those really small changes can really upend someone's life. And then thinking of the therapist and the physician, also very important to understand what we are recommending. And we kind of have to also have that extra layer of understanding how that person's clinical presentation, their specific needs based off of their diagnosis, is going to interact with the chair and with their environment. We also have the, kind of added layer of, it's really important to understand where that person is in their acceptance of their condition. Have they accepted where they are right now? Have they accepted how things might currently be changing or might change in the future? So we are kind of, taking on that role of helping to walk through that process and determine when to initiate that conversation for change. And then family members, also very important. I cannot tell you the number of times that someone's spouse is in there and I'm asking them about pain and they're like, oh yeah, I don't have any pain. And their wife's eyes bug out. And like, you complain all day. Tell them about your shoulders. So they're also very helpful. So as we are focusing on kind of that client specific focus as we are working through, the evaluation, we want to be assessing someone's readiness for change. That can be a very difficult conversation to initiate, but it is extremely important. So a lot of times I am asking very specific questions to kind of not only allow myself to understand how the device that they are currently using is meeting their needs or is not meeting their needs. Sometimes it's helpful to have the client say those things out loud, and because they might not be thinking about it. So do you have pain when you're pushing throughout the day? Do your shoulders ever bother you when you reach up to grab your coffee cup? Those kinds of questions, they're not really often thinking about. So we can frame that conversation in a way to then bring that information to them later if we are suggesting change. So we can also ask, are you open to change? Have you thought about anything? Have you gone on the internet, which is a dangerous place? However, it's available. And many people do look things up or they don't look anything up. So I often am, initiating that conversation. I have some thoughts. What are your thoughts on me making recommendations? And I included this small cat picture. I also work at a place that my clinic is called The Cat, so I had to include that. But change is hard. We have to remember that. And as we are working with someone, we have to delicately approach that conversation sometimes. So just to kind of continue with that, we really want to be focusing on that client specific goals for mobility. Sometimes it's, I don't want to change a thing. I like this. I've used it for 25 years and don't touch my chair. Sometimes they are able to identify those specific scenarios in which the device may or may not be meeting their needs. Do they have specific kind of functional goals? Yeah, I have noticed that it's harder for me when I'm propelling at work, or at the end of the day, getting my chair out of my car is starting to get harder. Have you thought about how your mobility might change over the coming years, given your prognosis or given some of the complaints that you have right now? And then we really want to be managing expectations. So when we are making new recommendations, it's really important to clarify what the chair will and will not do. I have, sometimes have this fear of going to recommend something and they think that it's going to solve all of their problems. Oftentimes that it won't. We might solve one problem. So it's really important to be, making sure that clients understand what those differences are going to be, and they understand that that device or any changes that we make will be different. It will likely require lifestyle alterations. That can be down to changing a component on the chair. So if I'm making the recommendation of changing from pneumatic airless inserts to pneumatic tires, that is going to require an adjustment. You now have some maintenance. You now have the potential that you might pop a tire. But, some of those benefits are reduced rolling resistance, lighter weight, improved shock absorption. So weighing what are the benefits, what are the downsides? And making sure that they understand. That can also go all the way up to if you have a manual chair to a power chair. Julie kind of said earlier, if they use a sedan and they break down their manual chair, recommending a power chair might now entirely upend their life. You, changing the seat height from a manual to a power chair. That is a big complaint I often get. I can't fit under my dining room table now. That is something that if it is important to you, that is something we need to consider. And then also recommending there will be a learning, or remembering there will be a learning curve. With all of these things, I always encourage demo trials. You should use it in the clinic. And then my ATPs know that if we are switching something, then they are setting up a demo for me and they are taking it to their home and they are using it for a long weekend or a week or a period of time. I kind of end that eval with, you have a lot of homework, my ATP friend and the client. You need to use this device where you think you are going to use it. If you want to switch from a mid-wheel drive to a front-wheel drive chair, you are driving it into and out of your vehicle. You're taking it into every room inside of your home. You're going to your common locations. You are calling the local ours is called Mobility Works. Is Mobility Works everywhere? You're calling Mobility Works and you're saying, hey, I am thinking about switching from a mid wheel to a power or a front wheel. What do I need to think about? Because I don't do that stuff. So we are really making sure they are ready to make that switch. So next thing we want to be open to is having some creative solutions. So like my cat meme, change is hard. Some people are really not open to change. But we want to be, so we might have a goal and they're not willing to change the chair. So what are some other things that we could can think about and consider? We have to think about the overall kind of health and well-being of that individual and recognize that changing the chair might upend their entire life. So what can we do to try to convince them into trying something new? So I am a big fan of reversible changes or reversible modifications. So for example, with the tires, you've always used pneumatic airless inserts. Let's try a pneumatic tire. You can call me in 6 months or my ATP and tell them you hate it, and we'll switch back. Or if we get thoracic lateral supports or get a truss strap just to try something, and you hate it, then you can take it off and it's like we never tried it. But at the very least, we're giving them the option to have an out if change is very scary for them. We also don't just have to look at the chair. This person is using their chair or their device in their environment throughout the day. So my dining room table example, can you raise the dining room table? If you need to stay in a manual chair and your bed height makes it an unlevel transfer, and that's getting more difficult, can we change the level of the bed? And then we're not touching your chair. Your seat height can stay the same. Other things, we can look at the individual factors. Someone has multiple sclerosis and their tone is continually getting worse. I get a number of individuals coming to me, their tone has changed significantly. They're falling out of position, they're falling out of their chair, and you get an eval for a seating evaluate or a referral for a seating evaluation. It's like, well, maybe let's look at your tone management and see if that helps, because I don't think the chair is going to fix this. So sometimes it's really looking at all of the factors that are involved in kind of all of those variables. So what do we do when the client goals do not equal the clinical recommendations? A lot of times, like I said, we're looking at those creative solutions. We're doing the best that we can. Sometimes, though, someone can be very fixed on a very specific something that they want. I will often kind of step back and, what are our safety considerations? What are our funding considerations? If I have serious safety concerns and I do not feel comfortable with ordering that device for someone, I have a right to also say, I don't feel comfortable ordering that device. And we as clinicians do have that right, and we do have that option. And that can be a scary and a difficult thing to say to someone, but we are allowed to do that. We also have to think about funding considerations. So if there is, some concern about someone's progression, maybe they are progressing pretty quickly with their condition, but they want to stay in the same device, or they want something that we might not deem as appropriate or might not work for that 5-year period. I'm often very transparent with people, and I will say, you are an adult, you can make your own decision. I will order what you want at the end of the day, as long as it's not entirely unsafe. And if you need something in 2 years and 3 years because you've had a major medical status change, or you've declined significantly, I will write another letter for you and I will submit that to your insurance. I make no promises what that insurance is going to say. I will do the best I can to justify that new device for you, because that is what I'm here for. But if your payer says no because you got that device 2 years ago or 3 years ago, there's nothing that I'll be able to do. So make your decision with that. But we also have to remember who's using the device at the end of the day. They get to make that decision. And if they have been in a manual chair for years and I think they should be in a power chair and I order them a power chair, they're going to stay in the manual chair. And that power chair is going to become a coat rack. So that's my soapbox. So another really important thing to remember is just with this population in particular, we really want to be having that ongoing assessment and follow up. They can have pretty drastic changes in a small period of time, or they can have drastic changes over a long period of time. So if we have any concerns with some of those faster progressions in particular, scheduling follow-up appointments, being proactive, on the delivery, let's get you on the schedule again in 6 months and check in. You can cancel that appointment if you don't feel like you need to come in, but let's get you on the schedule. Let's also empower our clients to pay attention to their changing needs. I often tell people, you don't need to know how to change the chair. You just need to know this isn't working for me. So, if you notice you're falling more, if you notice XYZ, that's a great call to me. Also, if you ever have any questions, I am always here 48 plus hours a week. So please just call me. And I will be happy to say, yes, you need to come in. No, that's not maybe something you need to worry about. And then we also rely on your referral sources. A lot of these clients, they have other physicians, other providers that they are seeing throughout the year. They have other individuals that they are seeing on an annual basis. So we have a pretty close relationship with our PM&R departments, our neurology departments. So a lot of times those physicians will see someone for their annual appointment and they come in with a list of issues that they have with their wheelchair, or they notice some changes. And then they say, you should probably go check in with the seating clinic and take a look. We also have therapists who are in the region who see clients for other regions, for PT and OT, and they know who we are, and they say, hey, I think this person should come and see you. They are complaining about their chair every session. Come and hang out. So it doesn't have to all fall on the seating clinic to be able to get these people into the doors. All right. I think you're first.
So this case study, a 67-year-old woman with MS for 35 years. Her current device is a Drive Viper. It's 4 years old, and she, a little history, was ambulating household distances about 2 years ago and being pushed dependently in the community, has had several repeated falls in the house, hip fracture at an ORAF a year ago. Still dependent for propulsion in the community, some assistance with wheelchair mobility in her house, but in general can kind of get from one place to the other in her home. A key part for this person, who is a real person, is that people in her life who knew things about the medical system, knew things, and wheelchairs led her astray. So that wheelchair was new when this all started happening. She wasn't able to walk in her home or outside of her home anymore. So she could not get another one. So just figure out how to live your life with this wheelchair. She had an insurance who would have paid for another wheelchair, but the PCP, the person who repeatedly fixed the brakes on her Drive Viper, did not educate her on the options for other chairs now that she's had a significant change in status. Walking around in your home to not being able to move at all in your home is a significant change in status. So I think that's a huge part, because we encounter people in the community. I'm not going to go up to a stranger in the grocery store and be like, oh, how old's that chair? But in general, when you know someone or we're in this healthcare world, it's also our duty to educate other people about that process. I cannot guarantee that someone's going to show up with a $50,000 power chair. However, she needs to have an eval. She needs to have an assessment of this, and we need to try. Her goals, once someone she was related to sent her a very long email explaining the options, were to improve independence with her propulsion so she could get places when she wanted to get there, to keep up with her grandkids, and to access tall kitchen cabinets and appliances. So honestly, at some point, probably 5 years previously, a manual chair with power assist might have worked well for her. She's walking around in her house. She didn't have an accessible vehicle. That could really have helped out in the community. That wasn't considered, it wasn't introduced to her. So at this point, we're not really looking at that because she is tired all of the time. She doesn't manage her position in her chair very well. And she doesn't even have real manual wheelchair skills to then add a rocket blaster to the back of. So that if transportation was a big issue or accessibility was a big issue, maybe we would circle back to that. But thinking about the fact that she actually during this amount of time bought a wheelchair accessible vehicle, she had an accessible home and was looking to finally make that next step. I would also add that sometime in that history of time, that 5 years where her walking really declined, she was also coming to terms with having a power wheelchair and what that looked like, the stigma of using that device. So that was playing a part in it as well. Once she realized she couldn't do anything she wanted to do in her current equipment, she pursued a power eval. So things that we would consider for her: is her home accessible? Yes. And does she have transportation for it? Also, yes. Wanting to make sure that she could propel it safely. This is another important thing as clinicians to advocate for. This device was evaled in her home and delivered in her home, and she did not go to any therapy or have any training on how to use it once it was ordered. So a lot of issues came up when at first, she's going from not even propelling herself manually and receiving a power wheelchair. She did not have the skills needed. She did not even know it was programmable to do other things. So, someone she was related to might have suggested she go see a therapist. Something else that she was able to receive on this chair was a seat elevator. And for the first time in 5 years, could microwave her own food, which was great. And I think just advocating for that for herself, she spent so many years thinking she couldn't have something. And when she found out she could have something, it really opened up her whole world and increased her independence, even as her physical function and cognitive function was declining. And that is huge. We can offer that to people, right? They're experiencing a lot of change in other aspects of their life, but we can improve that to something that they haven't even had for years. So that's really important and a huge component of that discussion. Her chair does not have a lot of other seat functions on it right now because of her current ability level, but because it's power, there's a lot of things that we can modify and change in the years to come.
All righty. So our next case is a gentleman who was referred to us. He was a 56-year-old male with a 37-year history of a C6 complete spinal cord injury. He also had some pretty significant bilateral shoulder arthritis and moderate joint degeneration with a right partial rotator cuff tear. So he was referred from one of our PM&R sports medicine physicians to look at his wheelchair and optimize it for his shoulder pain. So he was using a 20-year-old Tylite TR ultra lightweight chair, which was fully rigid and non-adjustable. And he also had an 8-year-old self-purchased Spinergy ZX1, which he really liked because he could independently mount and dismount from it. But his kind of key complaints that he had is that he is a very active individual. His shoulder pain was getting significantly worse. Right side more than left. It was really affecting his propulsion, his transfers, and just his overall quality of life because it was really, really starting to affect a lot of the things that he was able to do. And he had also received a number of corticosteroid injections to his right shoulder with really pretty limited relief at that point. So with the conversation that I had with him that first time, his specific goals were to maintain his independence and his active lifestyle, and also manage his pain and preserve his upper extremities, for years to come. He's only 56 years old. He has a lot of life left, and that arthritis is not going away. So we did have a pretty in-depth discussion about, there's not really too much I would change to your manual chair. He had pneumatic tires, he had soft roll casters, he had a rigid backrest, it was fully rigid, non-adjustable, so I couldn't actually modify that chair. And I was honest with him. If I were to order you a new chair, there's really not much I would change. This is set up very well for you. And then the other piece was funding. He had straight Medicare. So I was also honest. I can't get you a titanium chair. I also can't get you your Spinergy ZX1. because neither of those things will be paid for by Medicare. So your options would be one of the other power assist options that are coded and you don't like. And as we talked through every one, he was an engineer, so he had a lot of thoughts. And then we would have to get an adjustable titanium or aluminum frame, which would also be worse than what he currently has. So I was the first person to say, have you ever thought of a power chair? Um, that was a difficult conversation because that was something that absolutely was in the future for him. He was aware. He was not ready for the future to be now. So we, in that conversation, really talked about, some of the benefits of what a power chair would be able to do. He already had a very good setup. He already used a wheelchair accessible van. His home was very accessible. He actually lived on a big farm, so he has lots of land. He's outside all of the time. So with that initial conversation, he was pretty resistant and was like, oh, I did not come in here today thinking I would be told a power chair would be recommended. But so he ended up kind of leaving that day. I really was honest and was like, let's not rush this. Your chair is, for being 20 years old, it was in very good shape. So your chair is in good shape. Your shoulder pain not really changing at this point in time. We really need to think through before we jump into pursuing something. So I then worked with him, and my very patient ATP and manufacturer's rep worked with him over the next year and a half, answering lots of very, very specific questions in regards to options. My ATP took out 2 or 3 different manufacturers brands and mid-wheel front wheel drive chairs over the coming year and a half, and he tried them all at his home. That process initiated in April 20 or November 22 of 2022 and concluded in April of 2024. He now has a power chair. He still has his manual chair that he can use. He has his Spinergy ZX1, which still is working. And he has that power chair as that option now for mobility and protecting his shoulders.
Okay, last case, a little different. This is a 32-year-old previously healthy person who was in inpatient rehab for an initial diagnosis of Guillain-Barré syndrome, and then sometime in the next few months became a diagnosis of chronic inflammatory polyneuropathy with weakness, respiratory dysfunction, dysautonomia, dystonia, and a lot of other things. This person was very, very ill when I met them. And they came to rehab, having been out of bed maybe a few times in the ICU and then the step down unit, like could barely hold their head up on a lot of oxygen, not on a vent anymore, but a lot of oxygen, et cetera, et cetera. I think we can picture somebody like that. In rehab, we were using a facility demo group 3 power wheelchair. We started with chin steer. Head control came back relatively quickly. But then upper extremities were very, very weak. By the time they were maybe 2 weeks from leaving rehab, was using a standard joystick, but was still fatiguing quickly. And some of the aides maybe were bringing them to therapy sometimes still because they were so weak. So really, we were having this conversation. Are we really ready to not use alternative drives? They also had a stage 3 sacral ulcer from this prolonged ICU situation. So the client's goals were to focus on recovery and independence. Again, the initial diagnosis was Guillain-Barré, but also manage their fatigue and their sort of fluctuating symptoms. So initially left rehab because we didn't really know what was going on, and they sort of made a little progress and then got a little weaker and those sorts of things. Went home with a rental power wheelchair with a standard joystick with a lot of accessories, trunk supports, thigh supports. The plan was to rent it for 6 months and sort of regroup from there and decide if we need to purchase power or try something else. They actually had pretty good recovery, were semi-ambulatory for short distances, still had some fatigue, but transferring independently, Arms were much stronger than when I'd last seen them in inpatient. So started having this conversation about manual wheelchair. Okay, let's stop renting the power chair, try the manual wheelchair. And it went remarkably well, considering to have some recovery. And then so we ordered a manual chair, start there, but pretty adjustable. But had a conversation of, there's some stuff going on with your symptoms that seems like this might require some other things in the future. So we already had talked about potential need for power assist, and they were well aware of, all the pros of the power share for positioning, et cetera, 'cause having used one for quite some time, and discussed like if it gets back to that point, what that would be like. But yeah, so opted for manual in about a year, then needed power assist. Now had the correct diagnosis, but still had all these the whole time had some autonomic and other issues that sort of made their status change a lot. Yeah, at the point where they needed power assist, sort of already knew what the options were, the in the wheel, behind, et cetera. And that was modifiable, and the chair was modified multiple times sort of throughout those next couple of years. The whole time this sort of power chair was still on the table because there's a potential that they could need it with change in symptoms and function. They lived in an accessible-ish location, and they'd made it work with the power chair again initially after rehab. So sort of we're mentally preparing for what if I need to do that, what could I change for the long term? But again, I'm still currently using a manual chair with power assist, but sort of an example of how things with different diagnoses may sort of go up and then down and then up and then down and then really down. And then, those sorts of things of where the checking in more often and really knowing what options you have for modifying can be really helpful, and educating, that we could take it off and then we could put it back on, those sorts of things. So with that,